Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today we are talking with Andrew Fisher.
Hallelujah. 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 Hallelujah.
On the damage control resuscitation CPG. Thank you, Andy, for coming on to the podcast. If you would, though, please introduce yourself to the few people that have not heard about you.
All right. Hey, thanks, Dennis, for having me out here today. So my background is currently I'm a medical student at Texas A&M College of Medicine. Prior to that, I was a PA in the 75th Ranger Regiment. Spent about 10 years doing some stuff with them. Started at 1st Ranger Battalion as a PA in 2007 and ended my career to go to medical school in 2016, where I was at Fort Benning as the regimental PA. Currently, I am a PA still in the Texas Army National Guard and continue to participate as much as possible in, soft medicine, pre-hospital medicine, TCCC. I'm a committee member on a voting member on the committee on tactical combat casualty care. And that's about wraps it up, I think. Anything else I'm missing? Yeah.
No, I think you nailed about everything. Just all in all, a huge advocate for the combat medic and, the things you advocate for us. On these committees, has really helped combat medicine, I think, in the entire DoD, not just our little corner of the world. But what I would like to first ask about this the CPG is, what is the difference between RDCR, or remote damage control resuscitation, and damage control resuscitation?
Really, I think the biggest difference between the remote DCR versus hospital DCR is just simply where it takes place. There certainly are limitations that can happen, but when you take what's supposed to happen inside the hospital and put it into a remote area, we try our best to duplicate what takes place, but as you know, it's not always possible. As far as how do you define remote damage control resuscitation? I don't think there's any good one definition for it. It's people have tried to explain it. Could that be in a remote wilderness setting here in the United States, or is it maybe in a developing country and you're in a house sort of setting where you can't necessarily use the local hospitals or local healthcare facilities. So it's kind of a little bit of a nebulous definition, I think, and it just all kind of depends on your take on it and what your capabilities are in that remote setting.
What are your major priorities when you're doing damage control resuscitation?
I think first and foremost, I think you have to be able to master tactical combat casualty care. So you have to understand the fundamentals of that and accomplish those goals first before moving on to something like the damage control resuscitation. So priorities, obviously, then we obviously being able to control any hemorrhage, either from the junctional or limb hemorrhage, because a lot of what we do in damage control resuscitation has to do with the non-compressible torso hemorrhage that occurs in a significant number of potentially survivable deaths. After that, just going on down the algorithm of March, airway, respiration, circulation, etc., is very important. And once you recognize that your patient is in hemorrhagic shock or is going to need resuscitation, and you've accomplished those fundamentals, then it's about first and foremost probably starting some sort of blood transfusion. I think should where the emphasis should be placed, I guess, if you're going to start resuscitating.
And that's a really good point. How you highlighted it's more about the uncompressible hemorrhage, the thoracic trauma, the abdominal trauma, where you cannot compress the hemorrhage, that you're going to now do damage control resuscitation, versus if you have hemorrhage controlled with the tourniquet or whatever mechanism you have hemorrhage control, there's no great reason to keep a patient at a permissive hypotension, or what you would try and achieve in damage control resuscitation. There's no real reason to keep a patient their blood pressure that low. Is that correct?
Yeah, I think in the pre-hospital setting, actually, I think anything really, probably in these remote settings or prior to going to surgery, a lot of what we do would be considered, hypotensive resuscitation per se. But certainly there, if if someone has a amputation and they have a limb tourniquet in place, but they are showing they blood out to the point where they're having some signs and symptoms of hemorrhagic shock. I agree. There isn't necessarily a reason to be as concerned about, being careful with the resuscitation, or as careful with resuscitation as you might be with someone who may have, like a non-compressible torso hemorrhage.
Another thing on social media, I've seen you started up a course on hemorrhage control, an advanced procedure for hemorrhage control called the ERAPTOR course, where you learn about REBOA. Could you tell us a little bit about that?
Yeah, sure. So this was, I guess, I've been a huge proponent, as you mentioned previously, of different things in the pre-hospital setting, and trying to kind of push the limits of what we do, but to do in a manner that's one, safe, two, effective, and by three, have some sort of evidence behind it to support it. So with Dr. John Holcomb, Dr. Zaf Kassim, we started what is called the ERAPTOR course, but it stands for Resuscitation Adjuncts for the Pre-Hospital Transfusion and REBOA. And really what we're trying to do here is to educate pre-hospital professionals, both or whatever it may be, maybe a physician, paramedic, SOCM, 18 Delta, combat medic, nurse, PA, whoever it is, to kind of teach them in a way that allows them to potentially take the concept of REBOA to the pre-hospital setting. And we're really kind of try to get people to understand that this tool isn't necessarily just a simply go to something you can do, but it has to be carefully planned in a way that it's a team effort. So they have to be able to approach this as a team and understand the mechanism of injury, the potential outcomes that may happen, some of the adverse effects that come with this, but also that you really can't do this without whole blood. So we talk a lot about, performing proper resuscitation with whole blood on your casualty before stepping up and going to something as significant as REBOA. But yeah, we started this, and right now we're running the course out of Houston, and working with a lot of different vendors that kind of have helped made this possible. And of course, we're not taking a profit from this. This is simply, just to make sure that we're teaching people how to do this properly. And we got a lot of great experts that come in and help teach us, including Joe DeBose, Joe Love, and other people. So it's a fantastic course. Again, I'm not trying to make any money off of it. We're just trying to make sure we're teaching people the proper way to implement whole blood and REBOA for the pre-hospital setting.
Outstanding. Do you go over other hemorrhage control devices? Like, if I can't, it's not in my scope of practice to do REBOA, but are you going over other options for more non-compressible hemorrhage?
It depends. So we know right now that there aren't a lot of options for non-compressible torsal hemorrhage. So one, we cover things that all the way up to the junctional hemorrhage. So limb tourniquets, junctional tourniquets, wound packing, etc. But at the same time, when we get to the non-compressible torsal hemorrhage, we can't be so definitive about how to address these issues. We talk about the rescue foam, which seems to have a lot of promise, but at this time, it's not necessarily an option for really anyone out there. We talk about the AHAT or the abdominal aortic junctional tourniquet, and we talk about it and how it may be used either as an adjunct or as a primary tool, but there's certainly not a lot of casualties out there that would benefit from the AHAT. If there's a recent study that demonstrated that about 9% of the people who were in this cohort would have benefited from AHAT, where 96% would have benefited from REBOA.
Oh, outstanding. Just moving on a little bit farther down the CPG, under advanced capabilities, you talk about labs like INR, hemoglobin, hematocrit, lactate, pH-based deficit. Ultrasound is becoming a lot more common on Teams loadout for doing fast exams. They can do regional blocks. There's a lot of things you guys can do with it. But I'm starting to wonder, should things like portable lactate monitors be included in Teams loadout?
I don't think that we should limit any sort of tool that evaluates the patient status in a pre-hospital setting. If someone wants to carry a tool that will help them guide their resuscitation or give them information about their patient status, I don't see that necessarily as a bad thing, at least from the information that is discussed within the CPG. So ultrasound, fantastic. That can give you a lot of great information. Base deficit, obviously, can give you some good information. INR, give you some information. Lactate, I think, is a good tool. Unfortunately, I don't think we have a lot of great instruments right now that really provide us that, or I should say, that cannot be used in the pre-hospital combat setting. But that's only a matter of time before we're going to probably have a lactate monitor that we'll be able to use and will be affordable, and will probably meet a lot of the criteria that we're looking for in the military. I think there's a lot of people are calling for it, so it's just a matter of time.
Yeah, I think you're right. But in the meantime, we do have things like the EMA or some other type of end-tidal CO2 monitoring. Do you think these are reliable surrogates until we get these portable lactate monitors that are reliable and rugged?
Yes, I think again that any tool that is reliable based upon evidence and can be utilized effectively in the PFC situation should be considered. End-tidal CO2 we know is a decent tool that can give you some information about how your patient about the state about how your patient is currently doing, then you should be able to use it, and may help you guide in the resuscitation a little bit. Maybe not as much as lactate, but certainly can be of use.
Absolutely. As long as you understand how you got that number or what that number is actually telling you, not just following data points and making adjustments based on data points, but taking everything into context of what is going on, then making a decision, not just putting your faith completely in one number as you move along.
Yeah, I think that it's an excellent point that, you have to understand how these tools operate and exactly what they're measuring based upon, whatever pathway in the body, that this is kind of taking how they get, like I say, get that measurement. And then, not taking just one number. We all know lactate. If I take a lactate off someone who may be just injured, but they, were moving vigorously or through, through a target, and they get injured, there's a lot of anaerobic metabolism going on in the body whenever a lot of these guys are on target, plus they're already probably a little dehydrated. So they may have just a high lactate, initial high lactate. Does that mean that they're going to have a poor outcome? Not necessarily. I have to be able to trend that vital sign, if you want to consider the vital sign, or trend that lab over time to help guide that resuscitation. And also, like you said, you have to understand how that number is produced within the body.
Moving on to blood products. So best, low titer O blood for everybody would be the best. Under that, under better, you've changed the old adage just a little bit. The old adage being A for A, O for everyone else. Now it's changed to A for A, O for O, and low titer whole blood for B and AB patients. Pre-drawn whole blood on the battlefield is a very finite commodity. Do I save the pre-drawn blood for my B and AB patients, and then for my A and O patients, draw there in the field? Or do you think it's more of a first come, first serve type thing?
My belief, or I guess how I would go about it, is I think just simply based upon the numbers, I get more likely to have a group O casualty versus a group AB casualty. So I don't think it's necessarily, to me, makes sense to save that blood for someone who's AB. If your listeners don't know the kind of breakdown of blood groups within the United States, and a lot of Western Hemisphere, is we have about, I've seen numbers from about 45 to about 60% are group O. Roughly 40%, 45% is group A, and you get about 20% of B, and then AB takes up the rest, over 5, 10%, whatever. So in between there is some the truth, I guess. And I've done this at a lot of fresh whole blood transfusion training, is we'll simply ask, hey, who's O, who's A, B and AB. And typically it breaks down like that. They see about 50% are O, 40% are A, and then you break down between B and AB. Sometimes you don't even get AB in there because it's just not a lot of people don't. It's such a small percentage of the population. So I think if you were going to say this low titer for that group A, AB person that you may not even have, may not even be out there. And I'm not saying that you don't pre-screen for people who are on target, but I think we try to identify our group O people before they go out, simply because they can be donors. We're not doing a lot of screening for, hey, who's AB, so I know who you are. So I don't know if that's the best idea, is to save it for the group AB that may or may not happen, versus, having group O out there and group A, which probably are about, 80 to 85% of your people on target. Is probably better to go ahead and treat who needs to be treated with your group O. And again, if you're stuck in, like, maybe if you're in an ODA and you've got 12 guys out there, and that's probably a better time to do group A to group A and group O to everyone else. And if you have your low titer donors identified for fresh whole blood, then maybe they go to the B and AB, versus your regular O patients can give to any O patient.
Yeah, absolutely.
That makes sense?
No, absolutely. I mean, it just comes down to knowing what's the blood type of the guys you're working with. Having that on a sheet and being able to identify. I personally, I really doubt I would be saving my pre-drawn blood for, this patient that's a potential when I have one in front of me. And, I've watched how long it takes to actually draw blood. And even though, people will tell me, oh, I can do it in 5 minutes, or I can do it in, 6 minutes and 18 seconds. When I ask them to go ahead and do it, usually they're the ones that take 20 minutes to actually get a full bag. So, having blood on pre-drawn for me, I would just spike it and send it.
Yeah, and I think that's the best practice. I mean, again, we're not trying to. We can't necessarily determine, hey, who's going to be injured, when and where. So, yeah, giving blood to a patient that needs it is the priority. Yeah,
right. I think so. Another priority, I think, is also TXA. There's also a little bit of a change in this CPG versus conventional thought, in that if you do not have the saline bag to deliver TXA over 10 minutes, that it's okay to do a slow push. I guess my first question is, well, how slow is it? And the second part of that is, has the risk of hypotension because of a rapid push, has that not really borne out? Has it not really, we're not really seeing it like it's been advertised?
Yeah, I think if you look in the data, I'm not sure you're able to identify the exact prevalence of transient hypotension that is associated with doing a slow IV push of TXA. I've tried to find it, and I haven't really been able to tease it out of the information that's presented. So I'm not sure. I probably think that pushing TXA over, a few minutes in a syringe is probably safe. If you talk to people like Joe DeBose, who talk about in the Matters study, that there was a lot of people that were just getting TXA via slow IV push. So I think also, if you look crash too, there's probably a lot of people that had the slow IV push. So it's recommended. This is the way it's currently recommended within the TCCC guidelines to do it, hang it over 10 minutes. But I don't necessarily think from the prolonged field care perspective that it is a bad thing or an unsafe act. I guess it would be probably better worded. I don't think it's unsafe to push TXA via slow IV push.
Right. On the flip side of that, I've seen people, slam it home like it was adenosine or something, and I ask them, well, why are you pushing it so fast? What's the benefit of it? Really, the only response I ever get back is, well, that's how the Rangers do it, or that's how, this other unit does it, that usually this person is not part of. There is very, very few drugs that actually need to be pushed that fast. And, it's kind of a risk versus reward. I think if there was going to be a hypotensive event, it would be because of a very rapid push that didn't need to happen versus, a longer push over 1 minute. That's just good med admin, I think.
Yeah. No one is saying that you should be slamming this in, and you're right. There are not very many drugs out there that state push as fast as you can, and I don't think there are any protocols being utilized within the DoD that recommend slamming any drug in outside of things like adenosine, which if you're using adenosine in the pre-hospital setting, then in combat, then I don't know, maybe we got some, I'd like to hear about it, I guess. So slow IV push. No one is saying slam it in. Be safe with any drug you have. You should know how all these drugs can potentially have adverse effects on your patient, and how to maximize, or I guess I should say, how to minimize those adverse effects and maximize the safety profile.
Mm-hmm. So would you recommend having your blood on first, or your plasma on first, getting that started, and then pushing your TXA?
Ooh, that's I don't know. That's a good question. I I don't know if there's
On the chance,
go ahead.
on the chance that there is a hypotensive event, which is very rare, you would already be set up to start bolusing fluids to deal with that situation versus a more rapid push of TXA, and then you're chasing, a potential hypotensive event on top of the trauma that's already happened. Now you're in even a bigger rush to put resuscitation on board. I'm definitely a fan of TXA, but I think it's the blood that saves people's lives. So personally, I want to see people put blood on first and then worry about, the small leaks that are happening that TXA is going to fix.
Yeah.
My personal view.
Yeah, I think on some levels that may be a bit of a philosophical debate at this time, simply because we don't necessarily. I don't think we know. How what should be the priority, or if TXA is beneficial without without resuscitation with whole blood or plasma. I guess my perspective is what is readily available, how many medics are on target, and how many people that are not medics are trained to assist you in a manner that maybe they can do the TXA for you. We know in a lot of times, special operations, we do train the non-medical people to be able to perform those duties. Like, hey, get the TXA out, draw it up and give it to the patient. They're not making the decision on when to do things, but certainly can execute a lot of these tasks for you in an effort to kind of streamline patient care. My perspective is, I was out there by myself and treating a patient, I would agree with you. I'd probably start blood first and then go with TXA soon after, obviously in a separate line. So I think that's probably my perspective too. Yeah. I also think that, that is kind of a difficult one to discuss, I guess. Sorry about that. Now I'm just kind of rambling. You have to cut that last part out. But yeah, I don't. I get. Anyways, all right, I'm good.
No, I'm definitely leaving in. That's exactly the same thing I would do, Dennis. Definitely, that's probably going to be highlighted. I got one more question. Hypocalcemia during shock. I guess why does this happen in trauma patients? I mean, I understand them bleeding, but the actual hypocalcemia, I guess I don't actually understand. And should we now change how we describe the lethal triad to include hypocalcemia?
So, hypocalcemia happens in trauma patients for a couple of reasons. One, certainly you get consumption of calcium through the body's own mechanisms. But as we begin to transfuse blood into our patients, especially in massive transfusion, we start to see the citrate that is available and sort of the binding of calcium by citrate in the blood products. So I think it's kind of a multi-prong issue that causes this hypocalcemia. There is a mortality associated with hypocalcemia and massive transfusion patients. So I think it's important that we recognize that it's a possibility. There is we don't have a true good measurement of those in the pre-hospital combat setting that are hypocalcemic, but we do have a little bit of data from the Role 3 perspective, and there are a significant portion of those casualties that are hypocalcemic when they get to the hospital. So I think it's important that we probably give calcium early. I think after the first unit would be a good time to give a little bit of calcium. We talk about which one do you give? Do you have chloride versus gluconate? Calcium chloride is probably better, or more better bioavailability. but gluconate is much safer, and I think that's probably the best one to go to in the pre-hospital setting. It comes, the vials that are probably a little bit easier to carry than this, how calcium chloride is given to us. From the lethal triad perspective, and does it get added? I know it's kind of a hot topic within, pre-hospital medicine, TCCC, SOF, PFC situations. I don't know if we have the information enough to really say that it needs to be part of the lethal triad just yet, but I think it's a good discussion point, and I think it's driving a lot of good a lot of future research, PI projects, and other methods to determine if it does need to be part of the lethal triad. So I'm not going to say yes, it has to be or it should be at this point, but I'm saying I'm glad that we're investigating it in a manner that may provide us with the information.
It's, and as far as, talking about training your non-medics, I think as a medic, you're making an enormous mistake not training your guys to do, basic medical things. I mean, everybody's seen Saving Private Ryan. When the medic is wounded and nobody knows what to do, it's a really difficult time to now teach them. So just teaching them in basic T-Tri-C, which they're required to get, that's just good medicine, and if you want other things, being able to do good, draw up meds, which is a smart idea, take vital signs, which is another smart idea, and not necessarily make decisions based on that, but at least feeding that information back to you so that you can make decisions and then tell them what to do next. That you're just making a far more effective team in a situation that they probably are not training in frequently.
I agree. I think that's actually a huge point to maybe how PFC is going to be successful, but also how units like, my previous unit, like 75th Ranger Regiment, how we were so successful, and that is to train the non-medical people how to assist the medic and how to do certain things without the medic's, oversight. So I think we see this in TCCC all combatants, that teaching people how to address those, 3 most common causes of, potentially survivable death is critical, but also teaching, these people how, putting them through some sort of course that is, developed at the unit level, how to, hey, here's how you start an IV, here's the medication, here's what it does, and here's how you give it, sort of thing, and all sorts of different ways to approach it. Hey, here's how you draw a fresh unit of whole blood. Here's how you do a chest tube or finger thoracotomy, or thoracostomy, whatever it may be. I know within, like I said, SOF, we've done that very well, for both in group and regiment. But I also think now that you're looking in the conventional forces, you're starting to see this become more popular, that they are starting to train these non-medics to be able to do these tasks that aren't necessarily, you don't have to have a lot of medical knowledge to be able to do the task, and that's why the medic is there to make the decision that the task needs to be done, but you can utilize someone who just has the knowledge of how to do it.
Mm-hmm. Now, I think out of courses like Mountain Path or Dark Woods, or any of the other PFC type training I've seen where the entire team comes, personally, I think that's where the money is actually made, is in the team dynamics and in the non-medics getting trained on how to do a large variety of procedures, and then forced into a situation where they have to do it. For the medics, I see it more as not necessarily the different skills. They know how to do IVs, they know how to do airways, chest tubes, etc. But I don't think that they get a lot of practice putting everything together over a long period of time and having to make life-saving decisions, over 16 hours. They're used to doing it over 15, 30 minutes, and then it's done. So it's more of a rush of doing skills, not a lot of decision-making that needs to be done. I think that's the biggest takeaway from courses like that.
Yeah, I agree. That's excellent. And I think that's one of the great things that have come out of PFC, and part of what group and other special operations units have done. Simply from I'm familiar with the regiment perspective, and we have our approach with like advanced ranger first responder, and try to utilize them in the same manner as to bring them along to this training to ensure that they understand. So I love how Group has been able to kind of incorporate the whole team approach in order to ensure that everyone has some skills to be able to take care of, each person in the team if they were injured, because you guys do work in in a smaller element, and really, really need to have a good understanding of how to perform some of these skills.
Mm-hmm. Absolutely. Before we really delve into the training of things, because I think that's another podcast I would really like yourself, and or Ethan Miles on, is, how did the Rangers move to that 0 preventable deaths? That'd be another excellent podcast, I think.
That would be a good podcast.
Yeah. Do you want to do it today?
Do it today?
Yeah.
Without Ethan? We should, it would be good if we got Ethan on here too, and we could both do it.
Let's try and get him on, and I explain how that whole process of getting the command behind it. And then, that's how you make real change, is getting the command behind something.
Oh, yeah.
Outstanding. Is there anything else you'd like to add to this? Cool, man. Hey, thank you. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.